So thanks. We're so grateful to have you with us here today and on our board. I almost started like, hi, I'm Karen. I'm an alcoholic. It's a different meeting. Different meeting. Just was feeling it. I will start off by saying that the way I got into this field is that when I was 19, I picked up a felony. It was due to my substance use. I was lucky enough to look like I look and have parents that could afford a good lawyer, so I did not end up with a felony, but it changed the trajectory of my life. It was one of the best things that happened to me, even though in the moment it was one of the worst things that could happen. And it has propelled my work. I have done my best to give back and to connect with people in this work for over 30 years now. So I'm so excited to be moderating this panel and here with all of you, because obviously it's very close to my heart. So I'm going to start off. This is one of the panels where we intentionally have like a national perspective, more of a statewide perspective, and then a local perspective. Although it's LA, so it's sort of semi-statewide. So as I go down the row here and ask my panelists to kind of introduce themselves, talk about where they come from, they're going to weave in some of the amazing things happening at the national level, some of the statewide initiatives, and then what's happening in LA around overdoses. And so I'm going to start with Ingvild to my left.
And I have to get the mic. So I am really excited to be here. I'm Ingvild Olsen. I am now at Manat Health Services, which is a consulting company, and helping states and others really in this behavioral health space. But up until last July, I was the director for the Center for Substance Abuse Treatment at SAMHSA, where I've been for almost 4 years. And as an addiction medicine specialist physician and general internist, before coming to SAMHSA, I spent about 10 years in Baltimore City as the medical director for an opioid treatment program. And so I'm really excited to be on this panel, partly because all those experiences, one of the, I think, biggest experiences that has really shaped my career was as a provider. And as a provider who was seeing people come back from the Baltimore City Detention Center, from federal prison, from other jails and state prisons, and with untreated opiate use disorder, with lots of trauma, with mental health conditions that really had not been assessed and addressed in very effective ways. And as a provider, really also not at the time, I think, truly understanding what that experience had brought with them. And the experiences that they had had even before going into those carceral settings. So when I started at SAMHSA, because I learned a lot, and I learned a lot from the people who, my patients who were teaching me all about what those experiences were like, how it impacted their engagement with us as a treatment provider, and how over just years, because addiction is a chronic disease, and so kind of that length of time to really help people and be there to support them through a recovery journey was something that has just been an unbelievably rewarding experience for me as a provider and as a person. So coming to SAMHSA, one of the things that, at the time it was overdoses were skyrocketing, suicides were skyrocketing, and I really brought all those experiences with me, in particular, really wanting to make some changes in the population that is at highest risk for overdose. And we know that population are people who are coming back from incarceration. There are studies out there that show that people who are coming back from incarcerated settings are at 129 times the overdose risk compared to the general population. That is just, in this day and age, like unfathomable to me, and it's unacceptable, because we have really great tools and treatments for people with opioid use disorder that cut that mortality by over 50%. And so methadone, buprenorphine, we also have naltrexone, but really kind of focusing in on how can we get those medicines and all of the other wraparound services and all the other kind of counseling services and other pieces that I know we're going to talk more about. How do we get that to the people who are at that highest risk? That is a big challenge. And so when I was at SAMHSA, we really focused in on making sure that we had guidance. We created toolkits. We created opportunities for educational products, technical assistance, training through a number of different avenues. So we put out an advisory on how methadone can be accessed and provided in carceral settings that came out last June. We also put together a policy academy. So policy academies are where state teams come together. So they bring people from corrections, they bring people from the community, they bring people from, the treatment providers, really to then develop plans and concrete plans that they can then take back to their community to put into place. So all of that work, we ended up having policy academies with 15 states across the country to really try and advance those policies. At the same time, all of the Centers for Medicare and Medicaid Services developed something called an 1115 waiver that was really focused on reentry. And this waiver is designed to just very concretely make sure that people are getting access to all of the medical services that they should need before they actually, while they're incarcerated, and you can use Medicaid coverage in order to be able to do that, and then on reentry. And that when people are leaving incarcerated settings, that they have the medications they need in their hand, so that they don't actually have to go and try and now figure out, how do I get to the pharmacy? Where am I gonna, they're worried about lots of other things. So that has been something that I and Manat have been continuing to work with states and get involved in some of that work. And there are now at least 17 states that have one of those 1115 reentry waivers, which is really, I think, going to change the landscape. And the last thing I would say is that, I left SAMHSA in July at a time when also we had done a lot of work around not just on the carceral setting and the reentry, and really trying to change the language that we were using to make sure that we are using non-stigmatizing language to even talk about people who have behavioral health conditions. And really trying to promote harm reduction as an approach to where we're meeting people where they are, really celebrating and helping to support any positive change, however small that might be in someone's health trajectory. And a lot has changed in the last year or so, even in the last 6 months. I will say that those experiences, those things, and we talk more about kind of what some of those changes are, but it created a lot of uncertainty. And but I wanted to just highlight that just about a week and a half ago, there was an executive order that hopefully folks saw that really now says that the president is committed to a national addiction recovery initiative. It'll be interesting to see what comes out of that. But the second thing I wanted to mention was that just on Monday, there was HHS and SAMHSA put out a notice that they have created a $100 million initiative called the STREET Initiative, which is I'm not going to get the acronym right, but it essentially is taking and putting dollars towards targeted outreach, psychiatric care, medical stabilization, and really in treatment and connecting people with homelessness and experiencing homelessness and addiction with housing and stable housing. So the notice of funding opportunity is not out yet, but I do think that I just wanted to highlight that as something that, even in this uncertain times, that maybe there's some continuation of kind of this, the type of approaches that we also try to really foster at the national level.
Thank you. Doug, you want to talk a little bit about how the statewide initiatives, how you're rolling them out, and how you're experiencing them at Amity?
Sure. Yeah, Amity Foundation has been very dedicated to making sure that people have access to substance use disorder treatment as an alternative to incarceration. We also provide substance abuse treatment in every single prison across the state of California. It's one of the largest substance abuse treatment programs, coupled with MAT services in the country. And making sure that people have supports when they come home. So there are innovative programs, male and female community reentry programs that allow people to come home the last 2 years of their incarceration in a treatment facility rather than spending that in prison. And you see a dramatic reduction in recidivism. 3-year outcomes are about 50% reductions, which is pretty incredible to see. And then we also implement a lot of the CalAIM in REACH, which we started actually in LA County many years ago. Dr. Galley and others allowed these programs to do both in-reach services and then coupled with for some individuals, lifetime case management, housing, and clinical supports in the community. The CalAIM initiative has really been innovative to see. We're serving about 900 people right now in the pre-release part of that, and then helping with enhanced care management in several of the counties, connecting them with the treatment, housing supports, and other community supports as well. So those are some of the main, there's several other projects the organization works on, both with youth and adults. And I'll just say that, there are many departments. There's several in here right now: Justice Care and Opportunities Department, OICR, which are focused on both youth and adult and the care for them. That has been really incredible to see the changes on.
I love statistics. Fun fact, I'm a real big data nerd, so I love that you have both thrown some in. And I think Dr. Sai has some amazing statistics of what he's been working on in LA around overdose deaths. So let him have it, Gary.
Thanks, Karen. Great to see so many familiar faces. Yeah, LA, every year we serve about 250,000 people within our specialty substance use system. A lot on the prevention side. On the treatment side, we serve about 35,000. In 2024, we saw the largest reduction in overdose overdose numbers in LA County history, right? Our overdoses went down by 22%. The bulk of those were fentanyl, although methamphetamine was a major contributor to overdoses as well. It demonstrated that our investment across the continuum of services, prevention, harm reduction, treatment, as well as recovery housing, can bend that curve. The other thing that I think has been a great experience, innovative, has been our local implementation of the Reaching to 95% initiative, or we call it R95. Hopefully some of you in the room have heard of this before. What it refers to is the 95% of people with substance use disorders who aren't accessing services, oftentimes because they say they don't need services or they're not interested, right? And I think this actually gets at something that was touched on in the opening of this symposium, which is I view this as us looking in the mirror, us as a system looking in the mirror to figure out what we can be doing better, how we can better design the system to better engage the group of people, the very significant group of people who are not actually accessing services, right? I think we previously spent a lot of time on our system, on the services that we're providing, which obviously reaches those who are actually reaching out for services, right? And as discussed earlier, it does place responsibility on the individual to be ready for treatment, right? This initiative was actually founded on my experiences growing up with my mom with schizophrenia. We had a lot of challenges getting her care. A lot of those challenges were systems challenges. That's the reason why I am working at a systems level now. And it's all about reaching people that we need to be reaching that we haven't been able to. And briefly, it focuses on two main things. One, lowering barriers to care. So agencies that have adopted R95 have low barrier admission policies where they don't require complete abstinence, right? If someone's goal is to reduce their use or alcohol and they're interested in services, we want to open that door. They've also adopted discharge policies that don't automatically discharge someone if they use it. Doesn't mean that they can't be discharged. It just means As a policy, it's not an automatic discharge. It's something that the care team needs to sit down, talk about to make more individualized decisions. And then the other component of the R95 initiative is around system design. And so we've weaved this into our value-based payment approach that we've implemented on the substance use side in LA. And so we're providing financial incentives for agencies to do essentially A to Z walkthroughs of the experience of a client once they enter the door, actually even before they enter the door, and once they get discharged, right? How do you improve that process? How do you make your services stickier? In 2024, we saw a 5% increase in treatment admissions. That may not sound like much, but for those of you who work in the SUD field, our numbers have been very consistent in terms of the numbers of people we've served in our treatment system, and that was actually the largest increase we've ever seen since I've been there, which is about 11 years. I'm not ready yet to say all of that is attributable to R95. However, I do think that it had an impact. We're excited to track the numbers as we move forward, although I'm not excited about the impact that HR1 is going to have on some of those numbers. But
That was good. I like how you tied it all together. Okay, so, we talk a lot about reducing hospitalization, incarceration, and homelessness for folks living with mental health and substance use disorders. And we talk about those because they're three different systems, but I think we all know collectively that often it's the same human beings cycling through all of those. And so what I'd love to hear from the panel is what determines, when someone comes in contact with one of those systems, and for this purposes of this, we're kind of talking about the carceral setting, but it could be any one of those. What determines the interruption in that cycle, that they get connected to care and stop the cycle? What most determines that? And maybe I'll start with you, Dr. Sai, since we ended with you.
I mean, I think there's a lot of contributors. I tend to think of things, I know how important the individual level interaction is between that counselor, clinician, and the patient. I think that is probably the number one thing that will steer someone towards, a path to recovery or towards, relapse or other bad outcomes. That said, I think the system's role, in my mind, is to try to promote flexibility and the good things that frontline provider can do in order to steer the trajectory of that client. And at best, the system has to not prevent it. And I've actually seen instances where myths get created about policies, where barriers actually get constructed that are self-imposed. And so that's one thing that we tend to focus on at my agency is, how do we try to remove all the perceived barriers? How do we try to promote the things that we want? And with CalAIM payment reform, have been able to provide some dollars behind in terms of financial incentives via value-based payments.
Yeah, and I'll say some of the in-reach models is what interrupts that, coupled with care in the community. We have to make an investment of where our values are at and make sure that the resources are there for individuals once we've done that outreach, getting people into the right levels of care and appropriate services in the community. We have to be able to go inside, though, and build those relationships. And I'll separate out what we have to do in jails and prisons because I think they're very different in terms of the setup and structures. Less time in county jails, and you have more time with individuals while they're incarcerated. And so both require you to build relationships with them while they're inside, and then bring that treatment episode back out into the community and have continuity for that service as well. And what disrupts it's an investment in treatment, employment, or income and housing.
And I would just add, because I totally agree with everything you both are saying, is that there needs to be kind of a shared understanding of what all the challenges are, and then also what some of the solutions are, and what it is that we're actually talking about. And what I mean by that is really that having now kind of traveled across the country and seen various different systems and kind of carceral settings where they are trying to implement many of these models, is that and I think the the former panel really demonstrated that you have to have people in leadership in these different systems that really understand and are willing to learn, are willing to kind of open their doors to whether it's, you know, an in-reach organization or it's other people coming in and doing training and technical assistance and doing things in a different way. Because if you don't have that, then I think it is much harder for all these dots to kind of get connected. And for people then, the people who are actually moving through these systems to not get lost. Because I think it's the movement, but like whether it's somebody who's getting discharged from a hospital, you know, if they get discharged in the middle of, you know, the night from an emergency department and they have nowhere to go, then they're not, the chances that they're going to end up either back in homelessness or back in the hospital or in incarcerated setting is much higher than if you really kind of have those transitions of care that are much smoother, and having that shared understanding that there, and I mean, it's been spoken about earlier today, that we all have a responsibility to that individual and to working with that individual, and even if we're not necessarily financially putting in kind of the dollars. And so I think that kind of shared culture and that shared culture change is also a big, big piece of this.
Just one other point, and kind of builds on the focus on the individual, which is owning the person and not the system, right? So when you talk about siloed systems, and I'm gonna demonstrate some of my ignorance. I worked in a specialty mental health system for like 5.5 years. Never even heard of drug Medi-Cal, right? And no one in the system talked to me about drug Medi-Cal. When I saw my clients who had, you know, schizophrenia and meth use disorder, I would treat both. There would never be an appointment where I didn't talk about their substance use, even though I was also treating their schizophrenia. And so that's what I mean in terms of owning the person, right? And not the fact that, oh, I work in the specialty mental health system and this is the line that I draw. And once this condition crosses over, then it's someone else's responsibility. And I think there are a lot of state initiatives that promote that, right? Whether it's ECM or the fact that, you know, on the drug Medi-Cal side, prior to the drug Medi-Cal waiver, we couldn't even bill for care coordination or case management. After the drug Medi-Cal waiver, we could, right? And so these are all ways that systems can own the person as opposed to owning kind of all of the policies and the behavioral health information notices that are tied to that system.
That's awesome. Maybe I'll start with you on this one, Doug. Where do policy intentions, you know, we talk a lot about policy, you have policy makers and advocates in the room. Where do our policy intentions fall short when it comes to our intention to stabilize people living with substance use disorders?
Yeah, that's a good question. I'll say that we as an organization have had to do, as a direct service organization, do more on the policy side because we inherit good or bad policy. And some of the more challenging policy are the ones that don't include practitioners that at the end of the day have to implement everything that's being decided. When people sit in a room and think this is a really good idea, we need to test, evaluate, you know, adjust, and then use scale. So I think those are the things for policymakers, is figuring out how to include practitioners, always pilot, evaluate. I'll just share a story. Work with Dr. Galley in the creation of ODR, Office of Diversion and Reentry, and others. Krim Buchanan, who's now the Undersecretary of HHS, was instrumental in that project. We were able to pilot that program, and rather than going into a bad contract design, we're able to make real world changes after the contracts had already been initiated. We changed caseload ratios, we changed the ratios for mental health clinicians and other psychiatric needs for that program in real time. And if we hadn't have done that, we would have had a bad program design throughout. And that was a precursor to CalAIM that he then brought up and did that. And so being able to test that out, give feedback to government, have them change some of the policies that we thought were ideal when we all sat in a room and actually didn't work in practice was instrumental.
I love that, like this iterative process after a policy's passed. I think we don't always do that, right? Because we're just focused on the next whatever it is. And so I think that's a really great point.
Yeah, no, and I really appreciate that. It's not just kind of the practitioners, but it's also then people with lived experience, and that was what we did a lot of that also at SAMHSA to really just understand, does this actually resonate with you? Does it what would actually be helpful? And so having everybody, and this has been a theme I think kind of across this day, is really having everyone around the table in order to be able to then not only design the best policy, but then what happens in the implementation. Because you can never really predict exactly how it's going to roll out and how it's going to work until you actually do it. And then having that flexibility and that willingness of policymakers, of leaders to really kind of make those iterative changes. And doing that, I mean, there are models for also how you do that. Like there's something called the Plan, Do, Study, Act. So really kind of these quick, rapid, very just, it doesn't have to take years and years and years either. So I think that's the other piece to it.
Yeah, I would, over-regulation, I think, is one of the risks that I've seen in the substance use field. Some regulation's important, but when we over-regulate, good clinical care, is my belief, cannot be provided through legislation, because good clinical care is flexible. I mean, Doug talked about flexibility in terms of contracting, which I absolutely agree with, but flexibility in terms of how we approach individuals, what services we provide, is also critically important, and is what we need to get past some of the silos that oftentimes everyone's complaining about, right? So, and I've worked in the health system through medical school, mental health systems, through especially mental health, now drug Medi-Cal. Drug Medi-Cal is by far the most regulated system. Some aspects of it, opioid treatment programs in particular, get very specific, right, in terms of what we can and can't do. And I think that, some of that is the systems issue in terms of there's a reason why those regulations came about, right? So we have to hold ourselves accountable to not do things that we shouldn't be doing. And then some of it is also, frankly, I think some of the legislative process and, SUD voices need to be a greater aspect of that so that we could shape what that looks like.
Maybe just to put in a little bit of a plug for on the OTPs, although in California I understand they're called NTPs. So one of the big things that we did at SAMHSA is we revised those federal regulations at least. And so really to give much more flexibility and to kind of bring in that clinical judgment piece. And relevant, I think, to hospital or to carceral settings is we really emphasize that there is a piece that carceral settings can actually provide methadone for the treatment of opioid use disorder without having to be an OTP. They or NTP. They can use something called the hospital/clinic designation that then is through the DEA, and they do not need to actually kind of have a full-based OTP. And so there's still storage issues kind of related to the medications, et cetera. But I do think that is an opportunity that there are lots of state DOCs. So Washington State has implemented this in their state DOC, and also jails that are really trying to kind of figure out across the country how to take advantage of that provision. So I just wanted to so there's a state component to all of the OTP, NTP regulations as well, but just at the federal level, we made it hopefully a lot easier.
I was thinking about the story I told earlier about like watching my little people grow up and enter all of the systems in YOLO. And I did substance use treatment for a long time because that's what you do when you get sober, at least in the early 90s. That's what you did when you got sober. And I think what's striking me through the video about Doug and this conversation is that we do, as a society, vilify people with substance use disorders. We arrest them. We put them behind bars. And having, this lived experience in the treatment field, I know firsthand that every woman I ever gave an ACEs screening to in substance use disorder treatment had been sexually abused or sexually assaulted at some point in her life. And that's what often was fueling the substance abuse, that that it's so complex, right? That there's people living with schizophrenia, and actually sometimes the meth kind of helps. Or if you're living outdoors and you need to stay up all night, that really helps. So I think, yes, we're talking about substance abuse, but we're talking about so much more, because in so many ways, I think, I'm thinking of that Johann Hari quote that the opposite of addiction is connection. And I do think that's what we're saying, is like finding connection with one another is what helps people get better. Just a little moment of moderator privilege, that because I was feeling very passionate about what we were talking about. I think, so one of the things we have to talk about in California is housing, and it does relate to what we're talking about here. And so how do we in California think about housing and how it intersects with our folks that have these complex needs, and how we help them get housed and healthy and well?
Yeah, I'm happy to. What's one of the biggest challenges we have, honestly, that we face? I mean, as an organization years ago when I started with Amity, we would get people successfully through treatment, but then they end up going to a shelter and they didn't have employment or any source of income. And I think we fail when we do that, frankly. It's our obligation to not just say, okay, we've done our job and now you have to figure it out from here, and then wonder why people cycle back through. It's actually a federal definition. It's a 90-day rule on homelessness. And so if you're incarcerated longer than 90 days or in any institution, which includes long-term treatment, you're considered housed, which is absurd. I don't know very many people that have left incarceration that maintain their house. Frankly, I don't know anyone. And we work with tens of thousands of people that are incarcerated. It's one of the biggest hurdles, I think. It's one of the biggest issues for public safety and public health, frankly, in our community, is that barrier of not allowing people access. And we have to actually place them into homelessness, which is the most absurd public safety thing, in my opinion. I don't think I've met anyone in law enforcement or in treatment or any walk of life that thinks that's a good strategy. Some of the solutions on that is we are seeing this with CalAIM, short-term rental assistance. It's still a challenge because federal subsidies won't kick in for permanent supportive housing. Things like housing for health, which bypass that and said the cost of not housing someone is greater than the cost of housing someone, and it's often a pretty low cost. Some of what we do is we raise funds, we have state grants, we have other philanthropic partners, and we'll pay 6 months of rent for somebody that's successfully completed our programs. And that's been extremely successful. People don't need lifetime subsidy often. Most young people and youth and adults, I also want to say there's a lot of youth that are incarcerated as well, and their needs may be a little bit different, and I want to acknowledge that. But those kind of programs are hugely successful and don't cost a lot of resources. But if we don't make that coordinated effort after we complete and get people through substance abuse treatment, again, I think we fail.
I think most folks in this room know how housing and stability go hand in hand when it comes to any kind of behavioral health conditions, certainly substance use disorders. Even in housing first settings, they don't have policies around that restrict someone's use in the setting necessary, but they do have policies around behaviors. And when I speak with our housing partners, that's oftentimes the main reason why people end up getting discharged from housing first settings, is because of the use that results in behaviors that result in them getting discharged. And so one of the things that I'd like to highlight is the importance of recovery-oriented housing, low-barrier recovery housing, whatever we want to call it. Certainly the clients that we serve in our system, a good number of them prefer to be in some kind of recovery-oriented environment that helps to facilitate their recovery. And I think it's important that we view that within the lens of housing system, not purely through the lens of behavioral health. My agency does fund essentially all of the recovery housing in LA. And I've talked to our housing partners locally about this. I view recovery housing as a shared kind of responsibility. I think it's important when we think about funding, we also think about recovery-oriented funding through the housing lens. To DHCS's credit, with their behavioral health bridge housing, right, they did define recovery housing as aligned with housing first, right? And so kind of moving down that and viewing the full continuum of housing, I think, is important.
Yeah, and just maybe to add a little bit from the national perspective, There have been some changes kind of and if my colleague Richard Cho, who was an advisor, senior advisor to the former HUD administrator, if he was here, he would really be able to speak much, much, much more eloquently than I will try and channel him. Because right now, both between what SAMHSA had put out, I think last summer, as well as what the direction that HUD is moving in, is they are moving away from things like housing first. There's even starting to be questions around the role of permanent supportive housing. And so I think that those types of changes are absolutely going to be very important for all of us in the room and everyone kind of across the country to really be looking out for, and what that might mean for funds, to states, to communities. I will say that there have been also some, much of that is wrapped up in some legal challenges kind of at the moment, because there is a tremendous amount of evidence for housing first, for permanent supportive housing, that, short-term housing, even it's going to be really interesting to see what the Streets Initiative, kind of what that ends up looking like from a notice of funding opportunity through SAMHSA. Because short-term kind of transitional housing really, I don't think, is the answer for a lot of the people that we're talking about, and hopefully we won't go completely off in the direction of moving away from permanent supportive housing and even housing first.
Yeah, and just to be clear, I 100% support housing first. I actually think that should be the bulk of the housing available, but I think the comment was more around if you look at the housing continuum, the recovery-oriented aspect of that is usually what is the least.
Yeah. And it's really, I think it's all of the above, and really being able to have that menu of options so that you can really provide what people need and are interested in, and find a value.
Awesome. I think I'm going to take a little pivot. When we think about decriminalizing substance use, or maybe a better reframe would be like, if we think about treating substance use as a public health matter, Dr. Sayo, you'll love this one, and we use meaningful outcomes to kind of look at it, where does treatment capacity need to catch up? Like, if we were to make that pivot, what would we need to do in California to catch up treatment capacity-wise?
That's a great question. I think there's variability. I think some counties have fully leveraged DMCODS and significantly expanded, bed capacity, for example, residential bed capacity. In LA, we've expanded bed capacity by over 800% since 2017. There's financial advantages in terms of opting in the DMCODS in order to facilitate that growth. I think there have been other counties that haven't grown as much. And so what I would say is the fundamental challenge from my perspective that we have in the addiction field is around the issue of demand. Supply is important and it's needed, but demand, that's where the 95% comes from. Obviously 95% that's a majority of people. And if we can influence that, we will be able to make the most tremendous impact on people actually accessing needed SUD services. And whether it's decriminalization or other approaches, to me it's more around treating substance use disorders as a condition so that we don't penalize people for having that condition and essentially discourage them from disclosing they have the condition because they don't want to lose their kid or their job, or potentially actually inhibiting their access to certain services, right? Because as a psychiatrist, I've talked to other psychiatrists who will say, if I have someone who has a substance use disorder, I'll make sure that they get their substance use disorder addressed before I'll even treat their mental health condition, right? And so that's a situation where sharing someone's substance use condition doesn't actually result in better care. It goes in the opposite direction. I think that's something that we have to be mindful of.
Yeah, if I can on that, I think ideally jails and prisons shouldn't be used as a referring source to get somebody into substance use treatment, frankly. And I think that as we build out more capacity, the governor, as Daryl Steinberg mentioned earlier, has invested significantly in the infrastructure through Prop 1. I think you're going to see the results of that infrastructure. During the pandemic, we released 15,000 people early from incarceration, and the California Department of Corrections and Rehabilitation has systems set up for this, for treatment, recovery housing, outpatient, and other services in the community. worked with 58 counties, 58 probation departments, 58 health departments as well. I would not do that again ideally. Obviously, don't want to do that as a result of a pandemic, but we figured out how to early release 15,000 people and get them into beds safely in the community. And so I do think there's more the capacity if we look at 5 beds that are at this location, 10 beds that are at this location. There's 500 community-based orgs that worked on that project collectively. So I think if we had the same kind of urgency that we did during the pandemic to really address this, we'd be in a far better place.
I also think that if you look SAMHSA uses something called the sequential intercept model. And obviously, I also have to say, I can't speak for SAMHSA anymore, but just, based on my experience there. So really also kind of looking upstream at that model so that you're looking at trying to divert people from incarceration, even just from the very beginning. And then all the way kind of through to community corrections, because and the model that I have kind of in my head as well, California is doing a lot of really great stuff. Maine has a model of corrections where they've kind of flipped the whole approach to corrections on its head, and made it really, really, really just broad medical care, behavioral health care kind of in their corrections. They have a huge peer support network and are essentially training peer support specialists that then can get certified before they actually re-entry into the community. So a lot of really great things happening kind of within the correctional facilities. And I had the opportunity to visit a couple years ago, and one of the things that someone said to me was, yeah, no, we do a lot of also care coordination and engagement to try and get people, kind of housing and ongoing care in the community. But we actually now have people who are coming to the correctional setting saying, it's much easier for me to get treatment here than it is out in the community. That is not something I think anybody really wants to see. And so absolutely really thinking about kind of what is happening in the community in addition to what we're doing in the carceral setting is huge. And one piece was on that community corrections and training the community correction probation and parole officers in addition to all of the other correctional staff within the DOC in Maine, all of the wardens, all the sheriffs, kind of law enforcement, everyone, because parole and probation, community corrections often gets forgotten. And they are very often one of the biggest kind of touch points for people who then are coming out and then who can help. And the parole and probation officers, if they really are also on board, they can be a really big support and a resource to help people then avoid recidivism. So I just wanted to flag that.
Okay, so we're wrapping up our time together. I think we would all acknowledge, and most of us have been in this field long enough to see the pendulum swinging to, locking everybody up versus letting everybody out, and the answer is probably somewhere in the middle, maybe a little more on this side. So this is like the magic wand question, right? Is there something that gives you hope in our system right now that you think, if we just did more of that, if we just could do this, in a few years, we would have at least some portion of this issue ameliorated? I'm looking at you, Gary, to start.
Yeah. So I'm going to cheat and say, if we just invested more in the full continuum of substance use interventions across prevention, harm reduction, treatment, recovery, housing, in my mind, that's the only way to go because it's necessary to address all the points that someone could be at in terms of where they are in their recovery. Meaning, on the prevention side, obviously it's, saving $7 for every dollar invested, right? I would love to do that. And I think we have a lot of work to do to design our system. And I want to underline that word design, right? I think one of the challenges that we get with all of the different fantastic opportunities we have and all the new initiatives and all the local board motions that require us to implement all these different programs is we layer programs on top of programs on top of programs and generally don't say every 3 years we're going to reevaluate all of our programs and redesign it so that it all flows in a simple way, right? If we could do that, which obviously would be extraordinarily complicated, then we would end up with a simpler system that more people could access across that full continuum.
You know, if I had a magic wand, I'd invest more on the front end work and doing this years and years. We do a lot on the back end with individuals. By the time I was 7, I think I would answer yes to all but one of the adverse child experience questions on an assessment. So statistically speaking, I shouldn't be sitting here right now, frankly. We know where the interventions need to be at. We know it needs to be with children and families on the front end, but yet we're always willing to invest on the back end. Prisons are expensive, jails are expensive. It's not ideal to put everyone into a jail or prison for a lot of the social challenges that go on in our community. And I think that we should be looking at not short-term cycles. We shouldn't look at contract cycles, elective cycles for folks, and we should be looking at generational cycles. I'd love to see us start looking at more 30-year outcomes and how we're helping children and their children to never have these experiences.
And I'll just say, in a very uncertain world, I am actually really optimistic about the fact that this behavioral health conditions and also prevention, treatment, recovery supports, I'm going to say harm reduction because I think it still is. It's going to stay alive.
Well, you're in California, yeah. We're all in on
It
harm
is,
reduction.
yep. That I think this is also really a bipartisan issue. And I mean, we saw that kind of with all the SAMHSA grant cancellations that happened several weeks ago, that they were very quickly reversed. And I think the fact that we now have such awareness across the country, across communities, across sectors, everyone who is here, that's not going to go away. And we just need to kind of keep beating that drum that it shouldn't go away, because there is a lot more work to do, and there's a lot more work to do in all of kind of the areas that we've mentioned. Prevention, harm reduction, treatment, and recovery, and really making sure that we connect all the dots with the resources that we have, and keep also saying we need to continue that progress and continue to make sure that we're funding all of our services appropriately.
All right, please join me in welcome and thanking my panelists.